Thank you. It's great to be here, and it's great to see you all here. You know, especially I'm honored to be in the company of Pat Newman, who is one of my heroines. Today has been really, a lot of it has been the current system and how to work within the system. And I'm sort of an example of an alternative of working outside of the system. As a woman lesbian surgeon, when I finished my residency in 1979, I also got no job offers as Pat. And the reason I became a breast surgeon is I hung up my shingle, and the only patients they'd send me were women with breast problems. And so, God forbid I do a hernia. And so I realized how badly they were being treated, and that was really the beginning of my career and my advocacy. So I've done it in a lot of different ways. I've been in practice, I've done academics, I got an MBA, I've done medical device companies, entrepreneurship, I've done advocacy and researcher, and now I'm in a nonprofit. So there are lots of ways you can live out your career and really make contributions, and I just want to make sure you realize you're not stuck in whatever situation you're in now, but there really are a lot of alternatives. And through all of this, my position has been to be the advocate for the patient and how to make it better for the patient. Let me see, do I change these? I'm not very, who am I pointing at? No, but I was pointing the wrong way. So the question, this is really the cost of the cure. And having spent my whole career on breast cancer, I really realized when I had my own experience with AML that we don't do a very good job on the collateral damage of our treatment. And I realized as a physician, and this was certainly true of my physicians, you compare the patient to the people who died, and you're patting yourself on the head for having done such a terrific job. But the patient compares themselves to how they were before, and they are acutely aware of all the differences and what they've given up to still be here. And there's a real frustration and disconnect between the two. I know even with my own physician, when I said, you don't want to know about my neuropathy, he said, no, I really don't want to know about anything that I don't know how to fix. And that is sort of where we are. We don't ask what we don't want to know about. We only ask about what we have an answer for. Now, the survivorship research, unfortunately for cancer patients, is mostly done in clinics, and it's questions that doctors came up with, not questions that came from actually the patients themselves. So therefore, the known things, the thing that they're looking for or they think are there, they'll ask about, but they really don't make comparisons to people of the same age, and they don't seem to represent women's experiences. In breast cancer, this is really, it's such a complicated treatment with all kinds of different players in oncology, radiation, and surgery, and the treatment's fairly urgent, so you don't have a whole lot of time, or at least you don't perceive that you have a whole lot of time to sort it all out, and it's very scary. So even if the team is there, and even if they are explaining to you what's going to happen and your options and the potential complications, you don't hear any of it. When I was at the UCLA Revlon Breast Center, we used to, it was a while ago, we'd give people, we had a tape recorder, and we gave everybody a tape to tape the whole visit and then take the tape home and listen to it. And I still encourage people to record their visits with the doctor. And when we first started doing that, the doctors got really nervous, but then they found out that if you let the patients record it, they really listened to it later when they were less scared and could actually hear what you were saying. They had less questions, they called you less, and they had better outcomes. The current system of care with all the different doctors and specialty is often not a team. It can be in breast cancer from different institutions, and the information about side effects and toxicities are usually given when you're most anxious and least able to absorb them. And so it may be that you're telling the patient all the risks and complications, but they are probably not hearing it, or at least not hearing it in a way that makes it real. So the side effects and toxicities are really talked about in very general terms, and they don't talk about how they're going to affect the quality of your life. Chemo brain is real. There's some now good data about it and how they've done MRIs before and after chemo and shown these great holes. And that can really change people's lives, where they lose their jobs, they can't function anymore because of that. And yet we don't really talk about that. We really don't focus on those things. They have cancer and we want to fix it. So when I got back to work in August of 2013, I wanted to see if my experience was broader than it was and whether there really was a need for this. And so we put out a call on the internet, and we said, send us your problems, your questions, your whatever about the collateral damage of treatment. And I didn't want paragraphs, so I said, put it in the form of a question, like Jeopardy. And then that way we wouldn't have to read through a whole lot. And within 24 hours, I had over 1,000 responses. So this, quote, crowdsourcing seemed to be a good way to really get what was the real patient-reported outcomes, as opposed to patients filling out questionnaires reported outcomes. And we reached out to the Komen Foundation and the Young Survival Coalition and decided that we would do this big collaboration in October of 2013, Question the Cure. And we developed a project-specific website for participants to give us their issues with breast cancer. And we reached out to every advocacy organization that I could think of, and then some that weren't even breast cancer organizations, like the Neuropathy Association, in order to get the biggest amount of input that we possibly could. We put out the sign, and we got more than 9,000 responses and comments from more than 3,200 people who had had a history of breast cancer. And not surprisingly, some of the complaints were ones that we all, as physicians, know about well, and yet the patients were surprised about and didn't feel that they were told about. Fatigue was a big one, chemo brain, 18%, sexual problems, anxiety, depression, numbness, lymphedema. I mean, breast cancer, because you have surgery, radiation, and chemotherapy, and hormone therapy, and all that stuff mixed in together, has a huge amount of collateral damage. And the verbatim comments were really interesting. You know, how come I don't feel like I'm in sync? There are a lot of psychological. I'm constantly tired, regardless of how much I sleep. Will I ever stop worrying about recurrence? But then the chemo brains, I have issue with name recall. Is this related? Most of them did not feel like anybody told them that these issues might come up. You know, I have, why can't I remember songs I played on the piano? Do cognitive difficulties persist as long as 10 years following chemo? The answer is yes. How common is it to forget titles? Will my hot flashes ever stop? I've been waiting 17 years. Will my toenails stop curling down? And some of the questions were things that you know about, and some of the questions were things that I had never heard of, that people were finding as complications of the treatment. So to better quantify this crowdsourcing, we actually then developed, using validated questionnaires for our Health of Women study, which is an ongoing cohort study where we collect data from over 90,000 women with and without breast cancer. We put a questionnaire that covered all these topics using all the validated issues, and that was open to both women with and without a history of breast cancer, because yes, chemo brain is a problem, but for anybody who's in their 50s or 60s, remembering things is a problem anyway. And so how much of it is age, how much of it actually is collateral damage? And we released this in October of 2014. This is the Health of Women study. And as of February 2015, we had over 10,000 people who had completed the questionnaire. Anybody can do it. If you want to go on the Health of Women study and fill out our questionnaires, you're welcome to do so. You have to go to healthofwomenstudy.org, because if you go to healthofwomen.org, you get a Japanese porn site. Don't ask. Or maybe you want to go there, I don't know. But at any rate, we do periodic questionnaires about a variety of different topics. and are trying to learn as much as we can by going directly to the public. So of interest, we had about 2,760 who were less than 50 years of age, in part because we used the Young Survival Coalition as one of our partners, and they're women under 40 with breast cancer. And we had 517 survivors younger than 50. And their biggest problems were chemobrain, 44% concentration and multitasking. And you know what they're using for their chemobrain? ADD drugs, which they say work, actually. I don't think anybody's done a randomized study. I've actually found caffeine helps as myself. But they have a whole, some of them have had to stop working because of the chemobrain, and they really can't function. Some of them have lost their jobs, and it really is a significant problem. Sleeping is a problem, hot flashes, because we put a lot of them into menopause prematurely, or we give them drugs which persist these side effects, memory and remembering, and tiredness and fatigue. For being less than 50, with 50% of them complaining this, is really remarkable. Now our next steps are we're going to clean and analyze all the data. We're going to look for clues as to why some people get some side effects and some don't. And because, you know, could it be that there's a genetic thing that you have, or a SNP, that would predict that you're more likely to get neuropathy from the chemotherapy? Because not everybody gets all these side effects. Or are people who have a family history of Alzheimer's more likely to get chemobrain than people other? We've never looked at any of these things, because the studies that are done, the randomized controlled trials that are done by the drug companies, they're not going to look for this collateral damage. They'll only look for the side effects that they absolutely have to look for according to the FDA. And they're not going to expand it from that. And so how these drugs and how these things happen in the real world doesn't really get collected. And it doesn't really get collected in patient-reported outcomes either, because most of them are check marks and questionnaires. So if they only include the things they know about from the drug companies, then all these other things don't happen. And are there other predictors? I mean, are there people who have restless leg syndrome get more neuropathy? Who knows? We've never looked, we've never asked. So if we start to research some of this collateral damage and really take it seriously, then I think we can start to maybe refine things, and maybe there are some drugs that are better with some people and better with not with other people. But this has not been done at all in oncology. And then we'll share the data with research and back to the participants. So in the United States right now, there are 2.8 million people living with a breast cancer diagnosis. You notice I didn't use the word survivor. I hate the word survivor because it sort of implies that the people who died were somehow didn't do, you know, it implies that you could do something personally to do it, and that the people who didn't do it, it's their fault. So I think it's something that happens. You're living with the diagnosis, and you're trying to deal with the consequences. So the end, you know, my big message of all this is the cure is not enough. We have spent a lot of time in the breast cancer world focusing on the race for the cure, finding the cure, and we do cure a lot more people than we did. There's no question about it. We also treat a lot of people that we maybe don't have to. We over-treat a lot of people that we probably don't have to. And all of it comes at a significant cost, not just financial, but a cost in terms of collateral damage, where we're really having a huge impact. So what we try to do at the Dr. Susane Love Research Foundation is really, we're sort of see ourselves in the center. We have access to the women who have breast cancer through the advocacy work, through my book, through our website. We have access to, we do scientific research. We also are involved with clinical research. And so we're trying to pull all these things together. And as an ultimate outsider, I'm always the one, somebody said to me that I'm the one who says, you know, I think that guy that emperor doesn't have any clothes on. I think he's naked, when nobody else wants to say it. And that's the advantage of the outsider role, is that you can actually, if you embrace it instead of being upset about it, then you can really make a lot of change. So some of the things that we do at the foundation is we facilitate and research through the Army of Women. The Army of Women, as was mentioned, 375,000 women who have signed up to get emails about research. Now what we do is we don't match. We don't collect any data and we don't try to match you to a research study. We just send you out emails. And what we found is that works even better, because even though you live in New Jersey and the study is in Minneapolis, your cousin may live in Minneapolis and be perfect. So every time we send out a study, it gets virally sent out beyond everywhere. And we are able to really recruit everybody that people need very often within a week or two. Sometimes within a day or two, depending on the study. And we do studies not just in terms of breast cancer, but we've recruited for both, studies in terms of the collateral damage, treatment studies, metastatic disease. Most of them are not treatment clinical trials, but more having to do with understanding some of the issues both that make women at risk and men, and also the issues of treatment. The Health of Women study, as I mentioned, is our ongoing cohort study. Our current questionnaire, one of the hypotheses, one of the research projects we're working on is the microbiome of the breast. We think, we're so prudish in this country that we think sex doesn't happen. Everybody was so amazed that HPV caused cancer of the mouth and tongue. Like, how could that be? And in fact, the breast gets sucked on by babies and lovers. It probably has bacteria and viruses in it. And could there be a bacteria or virus that's involved in breast cancer? Sure, there could, but we've never looked. And when we looked in the past, we looked in the old way where we just tried to culture it. But now you map all the DNA and RNA and see who's there. So we're working on that. We have some very preliminary data. There could even be a protective bacteria, which, if you think about it, makes some sense, because if you were Mother Nature or God or evolution, you would want the people who reproduce to live and take care of their kids, and you wouldn't care about people who didn't reproduce so much. And so we all know that people who have early pregnancies and breastfeed have less breast cancer, and nuns have more breast cancer. So it could be that there's a protective bacteria, but we'll see. So our newest questionnaire, a little delicate, is trying to ask people about their mouth-nipple interactions to get at whether there could be a transmission of some kind of bacteria in that way. We translate science to the public through our inpatient science program, which is about to launch, our website and our outreach and giving talks and the book and all that stuff. And then we do inspire and do our own novel research. We do research that nobody else will do. So the microbiome study I've talked to you about, we're also trying to map the anatomy of the breast. Believe it or not, we still don't know how many holes are in the nipple. We don't know where the ducts are and what the anatomy of the breast ducts are. We've never studied it. And the breast, the pictures you look in the textbook, it looks like a pizza, flat with everything the same size, but actually it's not a pizza, it's more like a gumdrop. And the ducts, there's some ducts in the middle and some on the outside. So we're gonna try doing 3D automated ultrasound of lactating women, because they have contrast in their breasts with the milk, and see if we can't, if we do 200 women, come up and say, this is the dominant pattern, these are the variants, and then when you're doing surgery, you'll have a sense of how big a section you may or may not need to take out. And then the next step would be mapping the DCIS in the duct so that we can then do watchful waiting, or even squirt something down the duct and clean it out, Drano. If it starts in the duct, why can't we access it and take care of it? So we're working on that project. We've also got an NIH grant to develop a self-reading ultrasound. So the idea is that most breast cancer in low to middle income countries is premenopausal. It's mostly lumps. They don't have screening. And most of the lumps are benign, and they're pretty much the same on mammogram, but very different on ultrasound. So we're going to develop a device not unlike the cell phone that the person who's giving out the AIDS drugs or the healthcare worker will have in their pocket. If you have a lump, they can hold it over it. It'll give you a green light or a red light. And then that way the 75% that are benign will go home, and the 25% that could be malignant will be focused on. So this is the kind of stuff that we're doing. We collaborate with everybody, we work with a lot of different people, and it's an example of how we have to do this, because we can't just keep doing the status quo. We can stop diseases. In my professional lifetime, we have stopped cancer of the cervix. When I started, if you had an abnormal pap smear, you had a hysterectomy, because we didn't know what else to do. You lost your fertility. I had a cousin who had an abnormal pap smear. She hadn't been pregnant. She wanted to get pregnant. They said, okay, we'll give you a year. She went out, found somebody, got pregnant, got married. She was Catholic. And then got pregnant. And then right after she delivered, they did a hysterectomy. She subsequently got divorced. But that's what we did, because we didn't know what else to do. We cut out normal body parts to prevent a disease. Then we figured out you could do, cryo and less surgery. That was good. Then we figured out it was sexually transmitted. Then we figured out it was a virus. And lo and behold, we have a vaccine. In my professional lifetime, we went from cutting out normal body parts to having a vaccine. That's really amazing when you think about it. And there's no reason we can't do that again. There's no reason we can't do that with cancer of the breast. What do we do to Angelina Jolie when she has BRCA? We cut off her normal body parts. I mean, that's still how we treat breast cancer. That's crazy. We can find the cause. It may be a microbiome. It could be something else. I don't know. But we've got to look. And we can't just focus all the time on treating disease. We really have to focus also on eradicating the disease, because the collateral damage is too high, and we can be the ones that do it. And you, as Michael Landon said, you could die of the cure before you die of the illness, and it's true. I think, especially things like DCIS, which don't even go into cancer most of the time, and yet we still are cutting off body parts for that. I mean, the wisest thing is to prevent illness before we try to cure something, and prevention is better than the cure. So I'm going to do it one way or another. You're all welcome to join us. You can be part of the Army, you can be part of the house study, and if you have a good, innovative, collaborative study you want to do, let me know, because we'll be happy to work with you. We have to be willing. And now that being a woman surgeon or a woman doctor and a lesbian woman doctor is no longer such a rarity, we forget that we can change things, and we get sort of sucked into the status quo. But we can't afford to do that. We have to be the ones, the change agents, the ones that bring the change that's really going to revolutionize medicine. And I expect all of you to be on the front lines as we do that, whether it's in breast cancer or any other area. Thank you.